Hey, good afternoon. So it's my pleasure to talk to you too about two very important topics, osteoporosis and the sarcopenia. So as we can see here, the life expectancy is dramatically increasing all across the world, and especially in the developing countries. So with that, we as a clinician are facing a much aging population. And with aging, we lost bone, we lost our muscle, so that lead to osteoporosis and sarcopenia. And bone and muscle work together. We like to look at together as bone muscle unit, and it helps us to function, be performing in our life. So we know from this, osteoporosis and sarcopenia has profound impact on a person's health. So osteoporosis, by definition, is a loss of bone mass. So it destroys or weakens the microstructure of the bone. And so the bone is much more prone to develop fractures. Like here, it kind of affects the vertebral body, around the femoral neck, around the wrist, all has strong implication on person's health and the total lifespan. So this, as we can see, have a much big impact on global health. With the increased life expectancy, the people who are suffering from osteoporosis dramatically increase as the life expectancy goes on, and it affects both men and women together. So early detection and prevention and therapy is of very importance. So osteoporosis affects the bone, so it affects our whole human skeleton. And as we can see here on this pie, the spine involvement, vertebral fracture involves about almost half of the fractures that are caused by osteoporosis. So it's quite important. And also the vertebral fractures are unique in many ways because a lot of times come to clinical attention a little later, not acutely. And also is a good risk factor to predicting if the patient is going to develop more vertebral fracture or fracture elsewhere in the body. So recognizing them is very important. And we all know that DEXA scan is the most widely used measures to, diagnose patient with osteoporosis because of the low radiation. And we use that to diagnose osteoporosis and use as a risk factor for development of insufficiency fractures and also for monitoring treatment. However, it's very well known there's a big disadvantage because it measures the area bone density. So it's strongly influenced by calcifications and osteophytes around the vertebral body, which are very common in older patients. So this can lead to a well-known false negative results. Because of this, other measures have come into use. For example, quantitative CT, which we use a standard diagnostic CT, and we place another phantom. With calibration, we can measure the bone density very well, and it's very well documented in the literature. So because of that and the CT values that come to focus, it can be used for evaluation of bone mineral density and also the implication of osteoporosis and effects on vertebral body is well known in the clinical field. So there's a big need for opportunistic diagnosis of osteoporosis or the vertebral fractures. So the groups from the Royal Osteoporosis Society in England conducted a study and looked at the physiology, how it was applied around and what is the challenges arising from that. So here from the table, it listed all the different ways that people can use the CT scan to study osteoporosis. You can see there are many, many different ways, either using the calibration with a phantom or without phantom, then they all have decent results. So based on that, they came up with these principles about how to use this opportunistic analysis. So this highlighted there is a need for increasing awareness of this and also the challenges of how to effectively incorporate this into our clinical practice and made it a part of the patient's evaluation and how that impacts the patient's overall management of the patient's health. So this also gives us ample opportunities that are the area for research and collaboration with our clinicians as radiologists and how to improve the diagnosis and follow up on these areas. So in terms of specifically low-dose lung cancer CT screening, so this group in the Netherlands look at this, and then they look at a group of patients that participating in the lung cancer screening trial, and then they identified them and follow them about 6 years till their end of life, and then they use the CT image on the sagittal to look at the morphological changes of the vertebral bodies, also measurements of CT densities to look for vertebral fracture and osteoporosis. And here's what they find. They find very high prevalence of vertebral fracture on chest CT in lung cancer screening population, and also lower bone densities. So they thought there's doubling of all-cause mortality, independence of a lot of the risk factors like age, smoking status, and then their lung function activities and stuff. So overall, they felt the CT findings, chest CT findings could serve as a biomarkers for personalizing lung cancer screening intensity and for future disease screening, and also advocate more work to be done in this area. Sarcopenia is a gradual loss of gradual loss of muscle mass that leads to decreased muscle function here. So it's been well recognized. So now it's a disease that's coded by ICD-10 since 2016. And with that clinical awareness, there's kind of a little crisis on how we diagnose sarcopenia and how we categorize it and how we follow them. So right now, clinically, usually begin with a patient filled out questionnaire, and they do some measurements in terms of muscle condition. So usually by measuring the circumference of either upper or lower extremity and some of the simple muscle function tests. However, it's not, and also the biomedical impedance analysis, however, is not very well standardized. So there's a lot of non-standardization in there. So let's look at sarcopenia on imaging. And so we know that with decreased muscle, there's increasing fat. Okay, that's a very interesting phenomenon because it affects so many different areas. We can see, for example, on the top, that's an MRT1 image, and it shows the intramuscular fat very well, right? You see the posteriorly in that side, that part of the muscle looks much fattier, right? And also, it affects the muscle in a way that along the muscle fibers, there are the perimuscular adipose tissues. And also inside, there is extramyocellular increased fat. And even more, there's increased lipid level even in the myocyte. So it's very interesting. So here are the list of imaging modality we can use to study muscle. So of them, CT and MR stands out because the ability to do cross-sectional imaging, and we can see the fat disperse and infiltrate into the muscle better this way using Huang's unit and the different MR sequences. Because of that, the European Working Group of Sarcopenia of Older People in 2018 advocated CT-MR use for opportunistic sarcopenia evaluation, and they suggested L3 and mid-size as the levels. So with CT, and we have Huntsville unit, so we can do a threshold cutoff and do good segmentation of the muscles, and then we can do a histogram of the muscle composition based on the different Huntsville unit, like here. And the gluteal muscles and then the paraspinous muscles are usually the ones we study. So a group of the studies showing here demonstrate the muscle density is very well correlates with the muscle strength and the physical performance. So because of that, earlier this year, the Global Leadership Initiative of Sarcopenia Group have the consensus that morphological characteristics of the muscles, such as fatty infiltration and texture and density, should be part of the definition of sarcopenia. So this cemented use of imaging for diagnosis of sarcopenia. Here is an example of a CT histogram based on the density and Hanskell unit measurements, and it well depicted the different level of fats and also correlates with the involvement. So earlier, I know the speaker talked about the different part of the fat in our body. It's very interesting. So this is a study, very interesting, from a group in China. They used CT and MR to study various parts of fats in our body and age and the BMI's effect on them. So as you can see here, TAT is total abdominal fat, VAT is visceral fat, and then subcutaneous fat, and PS, ES are around the paraspinous muscle area, and the liver and the bone marrow. And then men and women, they both are affected by the BMI and aging, but different areas fat response or effects to it are quite different. So it's very interesting. And we know for opportunistic screening to work, all our physicians are facing with a big clinical burden. So this way has to be not very cumbersome and accurate. So AI and deep learning is a very good tool we can use. So here's an article that demonstrates deep learning-based fully automated segmentation studying muscle volume composition is very possible. And this group by Dr. Pihard in University of Wisconsin did a lot of work on sarcopenia. This particular study showed they compared the study at the level L1 and L3 of the muscle measurements and found them comparable, and they both can be used as opportunist prediction for adverse clinical outcomes in people with hip fractures. And, we all know chest x-ray is one of the most performed procedures in the hospital. And this Korean group even look at using chest x-rays, and they build models to look at if they can base chest x-ray for opportunistic sarcopenia screening and got decent results. So it's very promising. So with this come with challenges, that's well said here. And with challenges, it comes opportunities. So there's a lot of things we can do with opportunistic osteoporosis screening and sarcopenia evaluations. And they are now strongly aided by segmentation and artificial intelligence. And I think it's an important parameter about patients' general health that we can obtain with low-dose chest CT imaging that greatly promotes patients' health. Thank you.